Hello, everyone. Thank you for being here on Saturday afternoon. I'm Simon Laplante, a fellow from Toronto. We'll get started. Okay, I have no disclosures. We all know that laparoscopic sleeve gastrectomy is the most commonly performed bariatric procedure worldwide, especially in North America, and a good proportion of patients will go on to have additional bariatric procedures in the case of conversion for side effects such as reflux or insufficient weight loss or weight regain. Weight loss outcomes for patients who undergo these conversions to Roux-En-Y-Gastric bypass after a sleeve vary widely in the literature. Therefore, our goal was to determine the weight loss outcomes of patients who are converted from a sleeve to a bypass at the largest bariatric surgical network in Canada, and to determine whether the outcomes differ according to indications for conversion. In terms of methods, we had the Ontario Bariatric Network, which is in Ontario, Canada. It's made out of 10 bariatric centers of excellence, and each center has to do well over 120 cases a year to be considered. All the data goes into the Bariatric Registry, which is a multi-center database with prospectively collected and standardized data. What we did is a retrospective analysis of all patients who underwent gastric bypass after previous sleeve between 2012 and 2019. In terms of study design, it was pretty simple. We had two groups. Group 1 was a sleeve to bypass for insufficient weight loss or weight regain, and Group 2 was for any other causes, which I'll list later, but such as GERD, dumping syndrome, nausea, vomiting. In terms of patient selection, inclusion criteria were essentially adults over 18 years old with a BMI of over 40, or a BMI of over or equal to 35 with weight-related comorbidities, and anyone who had a sleeve to a bypass. Exclusion criteria were patients who had more than one conversion procedures. In terms of outcome, primary outcome was weight loss after conversion to a Roux-En-Y-Gastric bypass. We looked at percent excess weight loss, percent total weight loss, change in BMI. We had 2 time points, short-term follow-up, which was 3 months to a year, and mid-term over a year to 3 years. The secondary outcomes were looking at prevalence of comorbidities at the short-term follow-up only because we did not have data on the mid-term follow-up. In terms of results, we started off with about 99 patients who had a primary sleeve who ended up being converted for a gastric bypass. 9 were excluded because they had more than one conversion or revision, leaving us with 90 patients, of which a good amount had to be excluded, 42 of them, because they didn't have a single follow-up after the gastric bypass within the registry, the bariatric registry. That leaves us with 48 patients divided into 2 groups. Group 1, the weight regain, we had 33 patients, and Group 2, 15 patients. The indications for Group 2 for conversion were reflux in 1 patient, dumping in 2, drug intolerance in 1, nausea, vomiting in 7, dysphagia in 2, and not listed for 2. In terms of patient demographics, there were no significant differences between the groups, except for the initial BMI, which was almost 10 points higher in the Group 1, the weight regain group. In terms of comorbidities, Group 2, the reason for conversion, which was other, they had more diabetes and A1C was more elevated. In terms of the time to conversion, Group 1 was significantly longer than Group 2, 29 months versus 14 months. In terms of the weight loss outcome data for the short-term follow-up, so 3 months to a year, there was a bit of a drop. So Group 1, we had 30 patients. Group 2, we had 10 patients. And then the longer follow-up, the midterm that we call it, up to 3 years, Group 1, we had 30 patients. Group 2, 9 patients. So the midterm follow-up, there's a significant difference in follow-up, probably because the ones that are converted for another reason, the follow-up was with the surgeon's office and not within the bariatric registry. In terms of weight loss outcomes, so here we can see the results. I'll start off by showing the change in BMI in the short-term outcome. You can see there's a difference of 5 points in the Group 1 and 6 in Group 2, but there was no difference. It wasn't significantly different. In the midterm, same 5 points and 3 points for Group 2. Again, not significantly different. In terms of total weight loss percent caused by the bypass, we can see also here that there is no significant difference between the 2 groups. Here on the figure, you can see group 1 in orange and group 2, the other, in gray. And group 2 started with a lower BMI and group 1 with a higher BMI. And again, there's no significant difference between the two lines. In terms of comorbidity, like I was saying, we only assess those at the short-term follow-up and between group 1 and group 2. There was no significant difference. And then group 2, there was one patient that was converted for GERD and their symptoms went away, as expected. And in terms of the outcomes, so there was no significant difference between the two groups for all the comorbidities at follow-up. In terms of discussion, the conversion to gastric bypass, no matter what the indication was, resulted in a mean of 4 points lost in BMI at the midterm follow-up, so up to 3 years. The average, that's what I was saying, 0.2. And then 0.3, the percent total weight loss was similar between the groups as well. And the group 1 patients, however, were still in the class 3 obesity after being converted to bypass at 3 years. So that brings up the question of, what's the best revisional procedure to do with patients with higher BMIs. Limitations, lack of follow-up data for over 40% of the patients who underwent conversion. Most of them were in the other group, probably because after revision, patients follow up with their surgeon and not with the bariatric network. Also, the way it's laid out, we have 5 years data from the original operation. So 3 years after bypass could have been outside that area. Patients were followed, so that's it. And then conclusion, so conversion to gastric bypass after sleeve resulted in additional 4 points of BMI lost. Patient lost a similar number of BMI points and total weight loss, no matter what the indication was for conversion. And we obviously need more research to better assess to better determine the procedure we should do for these higher BMIs, whether it be a duodenal switch, SADE, or bypass. Thank you.